Hey, welcome. Today we're going to dive deep into what is, without a doubt, the single most important data set in any clinical trial submission, the demographics domain, or as we all know it, DM. Seriously, if you get this one wrong, the entire structure of your data can just crumble. So let's spend some time breaking down exactly how to get it right.
But before we get into all the technical nitty-gritty, let me ask you a question. When you're staring at this mountain of clinical data, labs, AEs, everything, which one single data set acts as the master key, the one that lets you trace everything back to a real person's journey through the trial? Well, you guessed it, it's the demographics domain. It is the absolute starting point for everything. So here's our game plan. First, we're going to talk about why DM is called the cornerstone of all clinical data. Then, we'll get into the weeds and look at its core variables. After that, we'll see where this data actually comes from, tackle some of those really tricky real-world scenarios, and even see how the official guidance has changed over time. And, finally, we'll wrap it all up with the key things you need to know to really master this domain. Okay, let's kick things off with the big picture. We need to really establish why DMA is the true cornerstone of our entire data structure. Its job is so much bigger than just listing a subject's age and sex. Now, the official SDTM implementation guide gives us this definition. It calls it a special purpose domain with essential standard variables describing each subject. And yeah, that's true, but it's the other part of the official description that really tells the whole story. And that's this phrase right here. The DM domain is the parent domain for all other observations. In the world of SDTM, that's a huge deal. I want you to think of it like the sun in a solar system of data. Every other data set, adverse events, labs, conmeds, you name it, they all orbit around DM. They all have to link back to that one single unique subject record that lives here. All right, so if DM is this massive cornerstone, what's it actually made of? Let's break it down and look at the essential building blocks, the core variables that give this domain all of its power. First things first, the identifiers. Now, study ID and site ID, those are pretty straightforward. But the real star of the show here is US UBJID, the unique subject identifier. This is the master key. This is the variable that links every single row of data in the entire submission back to one person and only one person. It's absolutely crucial. Then, of course, you have the variables that you'd expect. Birth date, age, sex, and race. These are fundamental for describing who is actually in your study, and you're going to see them used in just about every analysis. Now these variables define time. They frame the subject's entire journey. You've got RFI-CDTC, the informed consent date, that's the official start line. Then there's RFS-TDC, which becomes the anchor, the day one for calculating all your study days. And finally, RFP-NDTC, which marks the moment their participation ends. These three dates create the entire temporal backbone for that subject in the trial. And last but not least, the treatment arm variables. And pay close attention here because this distinction is so important. ARM tells you what treatment the subject was planned to get, what they were randomized to. This is essential for your intent to treat analyses. But ACT ARM tells you what treatment they actually received, which, as we know, can sometimes be different. Getting this right is a cornerstone of good clinical trial analysis. So we know what's in the DM domain, but where does all this information actually come from? I mean, it doesn't just materialize out of thin air, right? It's carefully pieced together from all those source documents. You know, building the DM dataset is kind of like putting together a puzzle. The pieces come from all over the case report form, the CRF. You're grabbing age and race from the demographics page, the consent date from the ICF, the planned arm from the randomization records, and so on. It's this careful process of pulling everything together to create that one single source of truth for each subject. Okay, that covers the basics. Now, let's get into the fun stuff, the complex, messy, real-world situations. Because, let's be honest, clinical trials are never perfectly neat, and the SDTM rules are actually designed to handle all those tricky edge cases. Let's start with a really common point of confusion. RFPNTC, the end of participation date. Sounds simple, right? But what event truly marks the end of a subject's time in the study? Is it their last visit? A final phone call? What if they terminate early? It can get complicated. And the answer to this really shows you how beautifully interconnected SDTM is. The answer isn't found on the demographics form at all. The right way to do it is to go look in the disposition or DS domain. You find that subject's final disposition event, whether it's completed or maybe lost to follow-up, And you take the date of that event, DSSTDTC, and use that to populate RFPNDTC back in the DM domain. It creates this perfect logical link between the two datasets.
Here's another classic that trips people up: screen failures. What do you do with subjects who sign the consent form but then don't actually qualify for the study? Well, the FDA is super clear about this in their guidance. You must create a DM record for them. You fill in their demographics, but, and this is the critical part, you leave all the treatment arm variables completely blank because they were never randomized.
The guidance around SDTM isn't static. It actually evolves over time to provide more and more clarity. And one of the biggest areas of improvement between older versions like 3.2 and the more modern 3.3 and beyond was exactly how we handle some of these complex DM scenarios.
So let's take on another one of those tricky cases. What about a subject who is successfully randomized to a treatment arm, but for whatever reason, they leave the study before they ever get a single dose of the drug? How are you supposed to represent that? Back in the day, during the SDTM IG version 3.2 era, this was a huge point of confusion. There was so much inconsistency across the industry. But thankfully, with version 3.3 and later FDA guidance, we now have a very clear, very logical way to handle this. Okay, so here is the crucial point, and the logic here is so important. You must populate the planned arm variables ARM and ARM-CD. Why? Because the subject was officially randomized. This preserves the integrity of that intent-to-treat population for analysis. But at the same time, you must leave the actual arm variables blank. This correctly shows that they were never actually exposed to the drug. This isn't just some small technical detail. It's fundamental for making sure you don't misinterpret both the efficacy and the safety data. Okay, let's bring this all home. Mastering the DM domain isn't really about memorizing every single variable. It's about understanding the core principles that guarantee you have a rock-solid data foundation for your entire submission. So let's just quickly recap the big ideas. First, never forget that DM is the parent domain. It connects everything. Second, know its key identifiers and reference dates inside and out because they give the trial its structure. Third, follow the clear, logical rules for deriving variables, especially for those tricky cases. And finally, always stay up to date with the latest guidance from the FDA and CDISC. A clean, accurate DM domain isn't just a nice-to-have. It is the absolute non-negotiable first step for a successful submission. I want to end by coming right back to this powerful statement from the implementation guide. It's not just another data set. It is the parent domain. Every single piece of data from every other domain is counting on it being correct.
So I'll leave you with a question to take back to your own work. Is your demographics domain a solid cornerstone, built to support an entire submission? Or does it have some cracks in the foundation that could threaten the whole structure? It's definitely a question worth asking. Thanks for joining me on this explainer.